Hello and welcome to this class on multimorbidity from the Department of Family Medicine at RCSI Perdana, University of Medicine and Health Sciences. I'm Professor Anthony Cummins. This is an overview of the class. First of all, why is multimorbidity important? What is the definition of multimorbidity? What impact does it have on individuals, families, and on the health economy? How to develop a multimorbidity consultation framework, and then we'll review two cases. Having viewed this lecture, you should be able to first of all describe the common problems associated with managing patients with multimorbidity. You should also be able to describe a framework for use in approaching patients with multimorbidity. You should then be able to apply the framework to enhance your management of multimorbidity patients, and using the examples we give of two case studies. And finally, you should be able to outline the impact of multimorbidity on health outcomes and on the healthcare system. Now, why is multimorbidity important? We'll look in sequence at the problems in both Ireland and then in Malaysia. You can see here this is a projected population graph from 2002 looking at the likely population outturn at 2036. And what you can see here, it's the higher age ranges which are increasing, particularly in women. So those aged 84, 85 and above, the numbers of those, although absolutely is low, proportionately remains high. So we'll have more elderly people living longer and longer, and these patients will have disease, chronic disease, degenerative disease. So those who increasingly now survive, let's say, heart attacks into their 80s are now developing life-limiting chronic heart failure, for example. And we know also that there is a huge burden of chronic disease within Ireland. This is a derived statistic, the disability adjusted life year. And you could see for a whole range of chronic diseases, particularly neuropsychiatric, but also cardiovascular, cancers, so on. These are the data in women in darker and lighter colors for men. This is from WHO data and relates to, I think it is in the mid-2000s. Similarly, looking at Malaysia, what about the impact of chronic disease in Malaysia? This data is somewhat older, 2002, but it shows that the burden of disease is largely due to chronic disease and multimorbidity. So if you exclude injuries and communicable or infectious diseases, then all of these here are chronic disease, and these constitute the typical multimorbidity pattern. Looked at again, you can see predictions from 2005 to 2015 for men and women aged 30 years or above showed that obesity due to raised BMI is increasing, particularly in women, and associated with that is the increased development of premature heart disease, stroke and type 2 diabetes, and also a rise in cancers. Other countries have shown that cost-effective interventions can work, and it seems that the best strategies are the employment of a mix of a population-wide strategy, a public health strategy, combined with interventions for individual patients. It's now well established in the media, and this is from last year, from FMT, which showed the top 10 causes of death in Malaysia, and these conditions are so prevalent they've given Malaysia the title Mortalasia. And you can see that of these 10 causes, 8 of them are due to the typical chronic diseases that we are discussing here in the context of multimorbidity: coronary heart disease, stroke, respiratory diseases like COPD and asthma, cancers, diabetes, hypertension, kidney failure and liver failure. So what is Malaysia doing about this? The Ministry of Health has developed a National Strategic Plan for Non-Communicable Diseases, NSP and CD. And this is an outline of the strategies, the 7 different strategies that are used. So there'll be both a public health based strategy with prevention and health promotion, as well as individual clinic management, encouraging concordance with medication, for example, and liaison with different groups, various NGOs and professional bodies. And clearly one has to monitor the progress of all these different strategies and use research to see what is working well and what can be promoted throughout the country and extended throughout, not just in urban Klang Valley, but also in Sabah, Sarawak and elsewhere, etc. So let's go back to multimorbidity and see, how do we define it? Well, it's basically defined as the presence of 2 or more chronic medical conditions, but there is multimorbidity and multimorbidity. And it's important to consider the concept of disease severity. So not all multimorbidity is equal. For example, well-controlled hypertension and stable asthma, by definition, in one patient is multimorbidity, but that could be very different from somebody with poorly controlled insulin-treated type 2 diabetes plus COPD, or somebody with a severe chronic psychosis such as schizophrenia, as well as brittle diabetes. There's a video here that you can view about the day in the life of this lady, May. This is an American video, but it's very well detailed, it's brief, and it's worth looking at. If you look in absolute terms, the prevalence of multimorbidity is greater among middle-aged people than the elderly at extremes of age. But the prevalence rates vary tremendously. In Ireland, for example, 66% of those aged over 50 in primary care. They have a mean of 7.5 medicines prescribed and a mean of 11 GP visits per year. That is much higher than your average adult without multimorbidity. And there appears to be an association between multimorbidity and deprivation as measured by various indices like the Townsend index or the Jarman index, and also underlying mental health. As you will see as we go through this video, mental health is a very important contributor and predictor of poor outcome. So in those living in deprived inner city areas, multimorbidity tends to occur much earlier than it does in affluent areas. And deprivation is directly associated with multimorbidity, particularly including mental health disorders, where the prevalence is almost doubled. The more chronic diseases one has, the more likely one is to develop a mental health disorder such as depression, and this in turn aggravates the outcome and makes the prognosis worse. So, for example, if you have one condition only, it's 23% prevalence, but if you have 5 conditions or more, the prevalence of depression rises to 41%. So what impact does multimorbidity have? Well, it has a huge impact on these individual patients. They die younger, they have multiple illnesses, their quality of life is much poorer. It's a very challenging condition to manage. These patients have to deal with many medications with different regimes. They may have poor physical functioning. And there's also a concept of treatment burden. It's a huge challenge to take 6, 7, 8, 9, 10 medications regularly, day in, day out. And it's no surprise that concordance with medication, which is also linked to poorer outcome, is a sad reality of having multimorbidity. What about impacts on the healthcare system itself? Well, clearly, the more conditions you have, the more likely you are to be prescribed more and more medications. You then run into the problem of polypharmacy with drug-drug interaction, adverse event, etc. There may also be a PIP, or potentially inappropriate prescriptions. So giving people a proton pump inhibitor for longer than the recommended 8 weeks, for example, prescribing sedative antihistamines inappropriately to older people, risking an increased likelihood of falls with the various implications that brings in its train. There may be increased use of the health services, more emergency admissions, and more emergency department visits. Also, the care may be very fragmented, so that individuals may get reasonable quality of care for individual conditions, but this may impact on their other conditions, but this is not coordinated, so the care becomes fragmented. It's also much more expensive dealing with patients with multimorbidity. And it is reckoned that by reducing avoidable complications by just 10% could save US dollars 40 billion. It's also hugely challenging for doctors to have the time to deal with those patients and deal adequately with their individual and multiple problems. So what sort of strategy should we use in approaching patients with multimorbidity? Well, there are three major central tenets of this. First of all, that care must be coordinated. It must be continuous. And it should probably be delivered primarily within primary care or family medicine. It can be quite chaotic dealing with multiple chronic conditions for the patients, and perhaps the best professional suited to coordinating this care is probably the general practitioner. It's very important that the care is continuous and there is adequate information given to the patients, and also that they are well managed with up-to-date evidence-based best care. Another problem is that they have short consultation times. Now, the figures quoted here are UK-Irish average, which is 10 to 15 minutes. But as you know, as students here in Malaysia, the average GP consultation time here in Clinic Kesehatan is 2 to 3 minutes. So it must be very difficult and very challenging to provide good quality care for multimorbid patients in the Malaysian setting. There are two areas here that are really important also because of the likelihood of harm to the patients by inappropriate medication or prolonged medication at inappropriate dosing. So medicines management through regular medication review is essential, but also want us to focus on the problems associated with care transitions. So when a patient is being admitted to hospital or transferred to a nursing home or discharged home from hospital, this is where most medication errors may occur. So, how do we manage a consultation with a multimorbid patient? The first thing is to make sure that you can identify the multimorbidity. Then you need to prepare for the consultation, so some work needs to be done in advance of even seeing the patient. You then need to have your consultation, and thereafter, during the consultation, prioritize the important issues and make sure the patient is informed and involved in shared decision making. But subsequently, there also needs to be a planned review. And you may need to consider other resources, that it may not be just the doctor involved, but it should ideally be a multi-agency approach. So that may involve orthopedic surgeons, occupational therapists, physiotherapy, pharmacy, etc., and a range of social supports. Throughout all of this and underpinning it is the realization that one should search for and identify and manage appropriately any underlying depression or anxiety. So first of all, identification of the multimorbidity. As we said earlier, the multimorbidity may be very complex, and it isn't just it's not the same for every patient. So patients with, let's say, stable asthma and controlled hypertension, though would by definition have multimorbidity, is quite different from somebody with uncontrolled heart failure and coexisting COPD. There may be huge problems of patients being able to function because of their variety of chronic conditions. There may be suboptimal management of individual conditions. There are certainly higher levels of polypharmacy, and these patients are burdened by having to see so many different specialists. So in preparation for this consultation, what should the doctor do? You should review the medical records, first of all. You should identify the multimorbidity. You should focus on any recent issues of relevance, and particularly disease-specific targets. So, for example, if the patient has hypertension, are they at target level? Is their blood pressure controlled or not? You should communicate with all the specialists involved in the patient's care. You most certainly should review all current prescribed medications in a formal medication review, as well as, this is in the preparation, but subsequently when the patient is seen, you should also review the medications with them and inquire particularly about any adverse effects. You should highlight priorities that occur to you for this patient's management, and this will be discussed with the patient during the actual consultation. So in the consultation, these are commonly encountered decisions in management, such as controlling targets like blood pressure, cholesterol levels, etc., managing chronic pain, maximizing functional optimization so that the patient is able to get on with their activities of daily living. You try to do everything to keep their independence, to maintain their mobility and so on. Regular medication review to minimize the harms of polypharmacy. But you may also need to consult widely in involving various other healthcare professionals, such as physiotherapists, even psychologists, and social supports. Now, these are services that exist in the UK and Ireland. Some of these don't occur in Malaysia. For example, the presence of a home help, which is a statutory agency providing help with those who are housebound. So, for example, doing their washing, ironing, and helping with preparing meals and so on. And the Meals on Wheels are a delivery service that provide regular meals to elderly, multimorbid patients. It's essential to assess mood and stratify their risk of depression, anxiety, and also to do a suicide risk assessment where that's appropriate. You may also have an eye for broader preventative health measures such as smoking cessation, vaccination such as annual flu vaccination or pneumococcal vaccination if appropriate. And then you come to setting priorities and sharing decision-making with the patient. The patient may have different priorities from the GP, so you need to balance these. You need to consider the burden of treatment for the patient. Do you really need to add another drug to this patient already taking 7 drugs? What is the patient's preference? And what about the patient's involvement in looking at the prognosis? So it's very important that they are involved in making decisions about their care. Clinical guidelines, such as NICE guidelines and others, are of some usefulness, but of limited use because they tend to be single disease focused. So there are trade-offs, and the patient's concerns might be different from what the guidelines will tell us should be the targets. Again, this bears stressing once more, assessment of mood is very important. And in relation to that, in managing low mood, for example, and suspected depression, psychosocial support will be very important, particularly in areas of inner city deprivation, where the presence of depression, along with multimorbidity, is quite common. There should then be a planned review to ensure continuity of care and considering other resources. So, for example, the GP, who would be the central coordinator of this approach to multimorbidity, and is a central player in this, and this is often very valued by the GPs. They value this continuity of care, seeing the same doctor regularly. This, of course, poses a burden for the doctor. It can be quite stressful. It can lead to burnout in dealing with these chronic multimorbid patients. It's important as well to have good communication and technical continuity so that the medical records are up to date, letters are received either by email or by post, that discharge summaries arrive on time, the medication list is updated, and communication throughout is maintained on a regular basis. This is all best done through coordination by the GP, but as part of a multidisciplinary team, including these other allied health professionals. And as I mentioned also, the quality of the person's life can be boosted by having an input from various social supports. Okay, so what are the take-home points about GP multimorbidity consultation. First of all, identify the multimorbidity. Provide continuity of care with one GP where possible. This may not always be possible. Prioritize the patient's functional optimization and involve other community-based allied disciplines depending on needs, occupational therapy, physiotherapy, etc. Always assess for and treat depression and anxiety. And just be aware that clinical guidelines have limited usefulness in these patients. Let's look at some cases now. Here's the first one. It's a 63-year-old ex-smoker with hypertension, ischemic heart disease, a previous TIA, chronic kidney disease, COPD, obesity, osteoarthritis, and chronic pain. This lady comes to see her GP. You may think this list is rather fearsome, but this is not at all unusual in primary care. These are her current prescribed medications. She takes aspirin 75 milligrams daily, bisoprolol 1.25 milligrams daily, ramipril 5 milligrams daily, atorvastatin 10 milligrams daily, amlodipine 5 milligrams daily, paracetamol 1 gram 4 times daily, salmeterol fluticasone, a combined inhaler for her COPD, and also a reliever salbutamol to be inhaled as needed, and finally amitriptyline 10 milligrams at night. So, prior to the consultation, you would look through her record. You are already aware of the condition she has. You now know the number of prescribed medications, which is 9 in total. And you read that she has previously been intolerant to a low-dose morphine patch, which gave her some dizziness, and also developed dyspepsia from an oral non-steroidal anti-inflammatory. You look at her chronic disease management and her targets. Her last recorded BMI was 35. Her BP is suboptimally controlled at 155 systolic, and her renal function is poor with an estimated GFR of 50, so she's now in stage 3 moderately impaired renal function. In the consultation, first of all, you have to look at it from the patient's point of view and find out what is the reason for her consultation. Well, she's effectively come to see you because from her osteoarthritis, her knee pain is chronic and severe and not responding to the painkillers, so she wants stronger painkillers. She's been taking paracetamol, but they haven't been helpful, so she stopped taking them. And because of the pain, she's finding it increasingly difficult to get around the house and to manage activities of daily living. She also feels that she needs a repeat prescription of her usual drugs, plus could you please give her something for her chronic cough? So let's look at this. Okay, there are various strategies we can look at here. We need to try and improve her functional optimization. She's clearly having difficulty getting around the house and doing her ADLs, but there's clearly also an impact of her very raised BMI, which puts her into obese class 2 on this chronic knee pain. We may need to bring in the idea of involving her in a weight-bearing exercise program, and we may need to use colleagues or our own strategies through motivational interviewing to help her to accept that this would be an important strategy to employ. You may refer her to a community-based physiotherapist for such an exercise program. Because her first request was for extra painkillers, you may need to explain to her the safety and logic of the WHO pain ladder. Now, she clearly has had a problem with non-steroidal induced dyspepsia, plus she also has chronic kidney disease. Non-steroidals in older patients with CKD can worsen the kidney function. They can also be associated with an increased risk of cardiac events, which is now becoming evident through research. So one should be very careful about using non-steroidals in older patients. She's also had the problem with morphine-associated dizziness. So you may reach a compromise and suggest a trial of regular paracetamol plus the addition of a topical non-steroidal and involvement in an exercise program. She might not accept that. You might have a challenge to get her to accept this. Her priority was about, in addition to the pain, about this chronic cough, and also she needed her repeat prescription. We know that she's got COPD, but also that she's been prescribed an ACE inhibitor, ramipril. So you need to check with her and through the notes, did the cough predate the institution of ramipril? And maybe get an up-to-date chest x-ray. You should also optimize her COPD management. If, however, the cough you think is associated with the ACE inhibitor, then you may want to substitute that with an ARB such as irbesartan. That would be quite a reasonable approach to see if that improves the cough. Regarding her repeat prescription, you would want to look at any potential inappropriate medications. So, for example, why is she taking amitriptyline? Amitriptyline is a very long-acting drug and quite sedative in older patients. The dose she's on is not an antidepressant dose, so it would not relieve depression should she have it, but it would certainly still give her the harms of oversedation. Oversedation in a limited mobility patient can give rise to falls, and she could end up with a fractured neck or femur or worse. You then need to organize a planned review so that you look at, for example, her blood pressure is not optimally controlled and her renal function is impaired. You may give her a 1-month prescription and arrange a defined follow-up visit. This is a specific visit on a particular day at a particular time. And during that, you will assess any results that are available and also reassess her blood pressure, reassess her knee pain on a visual analog scale, and reassess her cough. You might need to consider for future strategies referring to orthopedics or referring to occupational therapy to optimize daily activities. Let's look at case number 2. This is a much younger patient, a 36-year-old woman with a history of hypertension, asthma, and epilepsy who attends your practice. These are her current prescribed medications. She takes beclomethasone 200 micrograms twice daily, and she uses salbutamol as a reliever. She also takes ramipril 5 milligrams daily and is on carbamazepine 400 milligrams twice daily. In your pre-consultation, you'd identify the various illnesses from the medical record and the number of prescribed medications, which is 4. You look at difficulties with care coordination. So you discovered that she's had no asthma or epilepsy review for the previous 18 months. You notice also that she has a pattern of attending only in crisis and seeing different doctors, but then fails to attend for recommended further follow-up. You also know that her concordance with medication in the past has been documented as poor. Now, what is her reason for the consultation? Well, when you see her, she tells you firstly that she needs emergency contraception for an episode of unprotected sexual intercourse a day before. She already has 3 children, and she tells you that as far as she is concerned, her family is complete. She also, apart from this request, complains of fatigue for about 2 months. She reports that she has difficulty sleeping and that her mood is low. So what are the priorities? Well, she needs effective contraception, that's important, and at the moment she needs emergency contraception. Now, because she's being prescribed carbamazepine, which is a cytochrome P450 enzyme inducer, this will antagonize any oral contraception, and therefore a better approach would be to give her an IUCD. But thereafter she would need regular contraception, and maybe because of this, the best approach would be either 3 monthly Depo-Provera injection or an intrauterine system such as Mirena coil. This can be left in for 5 years, so it's worth giving her information on this and allow her to make her decision. You need to assess her low mood, and you would do this by using a validated questionnaire such as a PHQ-9. And if she scores moderately or severe, then consider an SSRI plus or minus a referral for cognitive behavior therapy. I stress here, if available. The difficulty with CBT is cost and availability often, and it may not be available in your area. There is also computerized CBT, which may be a reasonable alternative. But sometimes you may have to prescribe only an SSRI, as these are not easily available or affordable. You might want to do some bloods to check other causes of fatigue, check a full blood count for anemia, check a Usinase, and so on. In the Irish context, you may also want to check for celiac screen because celiac disease is quite common. You may or may not check carbamazepine drug level, mainly for toxicity or for a low or absent level suggesting poor compliance. In terms of efficacy, there's not a very strong correlation between the level of carbamazepine in the blood and the effectiveness of the drug. So it's more used for compliance and toxicity reasons. You arrange a planned review for 2 weeks, in which case you assess the initial response to the SSRI, review the full blood count and other results, and also discuss with her about effective ongoing contraception and discuss what her choice would be for this. It's very important to emphasize, given her past history, the importance of follow-up and also giving her a written reminder. You may follow this up also with a WhatsApp, a phone call, or a letter. You may then want to broach broader concerns about chronic disease management, for example, for her blood pressure, for her asthma, and for her epilepsy. These are some useful resources, and if you look on the RCSI Perdana Family Medicine YouTube channel, there's a short video on apps in family medicine. Finally, here's some resources, and thank you for watching the video. Thank you.